Okay, good afternoon. This is pretty easy. Dr. Wu, we're lucky to have Dr. Wu. He is Associate Clinical Professor at UCLA, and he is the Psychiatry Clerkship Director. Don't let that sway you, all our psych folks who want to go into psych. If you have the good fortune to rotate with him at all of you UCLA, you'll be in great hands. He is also very involved in geriatric psych and has done a great deal of research in Asian American health. Please welcome Dr. Wu.
So good afternoon, everyone. So let's try to go through the lecture so we end on time, okay? So I was kind of thinking about how to talk about psychiatric emergencies. And one of the things that I thought about was, when I was a medical student, how did I learn about psych emergency? And I have to count my blessing, because when I was a med student at UC San Diego, basically I ran into a mentor, and what he taught me was, well, if you want to learn about psych emergency, you need to do research. So the first thing that I did was, while I was sitting like you guys, I looked at 79 medical charts at the Senior Behavioral Health Unit at UC San Diego. And at that time, the patients that we studied was approximately 78 years old. Old enough, but nowadays, to most of us future doctors and current doctors, 78 years old is pretty young. Some of the diagnoses that we ran into were psychoses, like people were hallucinating, they were having delusions, or they were thinking that their wife is cheating on them. Does that happen a lot? Enough of time. And enough of them were having depressions. Some of them were thinking about hurting themselves. Others were just kind of like lying on their bed, having problems, not able to kind of focus and concentrate. And enough of them also had dementia, cognitive impairment. So what do you guys think may be the cause of the psychiatric emergencies of these patients being brought into an elderly ward? Anyone? Benadryl? Good one. Actually, that's something that we'll be talking about like in the later slide. But before I give you guys the answer though, let's kind of talk about what do I imply by psych emergency. So when I usually work on the inpatient ward that some of you guys will get to rotate in your third year, breaking window happens once every year, hopefully. So I'm always counting my blessing that no medical students have been hurt in a major way yet. So let's hope that doesn't happen. So that's why it's important to learn about psych emergency. But let me give you a little story that I was working at one of the psych emergency room. There was a patient who was kind of getting psychotic and was kind of thinking like, I'm the guy who stole his identity. And we were both in this locked room. And I was kind of thinking like, why is this guy putting his hands like this? And I was like, something doesn't feel right. So next thing I know was I was walking close to the door, and he took this out, and that's the knife that he was trying to throw at me. So when people get psychotic or when they get angry, or, if one of you are upset at my lecture, who knows what you guys are going to throw at me, right? But how I determine psychiatric emergencies are very straightforward. To me, any kind of disturbances in your thoughts, meaning if you are trying too hard to study for your step 1, and I see you in the library with, all kind of junk food and everything, that's part of it, right? Your disturbances in feelings, right? Or any kind of actions that require immediate treatment. So kind of keep in mind, it could be any one of us sitting here, getting drunk, and the next thing you know is you kind of act out. And you guys remember that Florida neurology residence, right? So kind of keep that in mind. So do me a favor, if there's one thing you remember from this lecture, even if you get your licenses, try not to get drunk and start attacking the Uber driver. Okay? So that's psychiatric emergencies that happens in my house. That's my cat. All right? So let's go back to the first research that I did when I was a medical student. I was so shocked to find out that about 1/3 of the patients that we were dealing with actually had medical problems. And the first big medical problems that I learned was constipation. And I was thinking like, really? Someone being constipated and you were gonna have, psychiatric emergencies? But I'm sure, you guys could kind of think about it. Imagine the time that you were really, really constipated. And you were sitting down on your own SHIT. And next thing is, one of your loved ones come by and you start to have a little bit cognitive impairment. You don't remember when was the last time you went to the bathroom. And your wife is like, honey, what's going on? Why are you looking so sad? Next thing you know is you used a cane and you got brought into a psychiatric ward. So what's the treatment for this kind of psychiatric emergencies? You guys will be doing enough of this, okay? In your third year medical school curriculum, if you don't do at least one of them, rectal exam. All right, so that's the treatment. Pretty straightforward. You solve it, the elderly become normal, they don't have to stay in a psych ward. You guys did the human mankind the biggest favor. But if you guys look at the second one though, and the fourth one, urinary tract infections and pneumonia, do remember that a lot of times our elderly population get their infections and they look a little bit disoriented. And if you are their family members, you are unable to tell whether they're suffering from infections or whether they're truly having a psychiatric episode. So that's the time that when we really need to order labs, order chest x-ray. So those are the things to really think about. And number 3, hypothyroidism. Basically, 1/3 of your geriatric depression could be due to hypothyroidism. And it doesn't matter, they didn't have hypothyroidism before. So it's very important in a psychiatric emergencies, if you have a safe way, draw some blood, and hopefully you will determine the cause. Usually in the psych emergency room that I work with though, I count my blessing if I could get their urine in a safe manner. And the last thing that I would ever do is to send one of you guys to hold a pee cup. But at the same time though, do remember, if you have different ways to kind of calm the patient down and be able to get some labs, it's gonna go a long way to solve your mystery. So before we go on talking about different kind of psych emergencies, I want to do a little advertisement for my program. You guys will be coming to us in third year. Each month we have 4 spots, and we are basically one of the 3 Los Angeles County psych emergency rooms. So with us, you will see anything as simple as a classic schizophrenia lying on the street, now coming into the psych emergency rooms. Your typical borderline patients that kind of cut their hands and do a lot of crazy gestures to scare you guys, as well as your classic medical problems that looking like psychiatric illnesses. But if you come to us, you will get to see a lot of psych emergencies. So in California, and I know I'm kind of talking to some folks in Oregon also, which they have a different law, but at least in California, we go by what's known as 5150. 5150 is basically a way for you guys to be kept in the psych emergency rooms due to being danger to themselves, danger to others, and or gravely disabled. Gravely disabled means that you are unable to provide for food, shelter, or clothing. Anyone here from like Ventura County by any chance? Ventura? Wow. Anyone from the valley, the central counties like Fresno? Over there, basically, if you're able to eat from the trash can, rotten food, if you're able to have diarrhea, you are no longer considered gravely disabled. So if you are from one of the lesser affluent counties, that's how it is. In Los Angeles, Suicidal, we're a little bit better. If your mom or dad said that you were having a mental illness, you were not taking your medications, and because of your psychosis, you are unable to stay at your house safely, we count that as gravely disabled. So basically, when I become an attending at Oliveville, one of the things that I kind of ask myself is, now I'm dealing with a nastier population. This is a group that was being brought to us by the police. Does my medical illnesses-driven psychiatric disorders happen again? And lo and behold, enough of the patients being brought into us suffer from altered mental status, hypertensive crisis, pneumonia, renal impairment. So I guess one of the take-home points that I have for you guys is, right now you guys are learning the psychiatric aspects of the medical school, but do keep up with your medical knowledge, because a lot of times we rely on you guys coming as third-year medical students to make the right diagnoses. One of your graduating fourth-year students actually helped us to make a diagnosis on a psychiatric lady that was kind of like peeing in the car, kind of talking nonsense, and we're just kind of like not making sense. Everyone thought that she was suffering from schizophrenia, but this wonderful medical student actually came up with the right diagnoses, ordered the CT scan and the MRI, and we actually saw some fingers on his brain imaging. Anyone knows what that is? Wilson's, all right? What kind of fingers? Strong work. See, everyone knows. Now you guys are going to remember. See, I would have brought that picture with me, but the only kind of imaging that I would find is like the Simpson, images with the fingers. So I'm not going to torture you guys looking at that kind of imaging. But now, let's talk about a case that I run into at Oliveville. So we have this 60-year-old gentleman who basically wandered on the street. And the only thing we know was that he lost his family members for the past few years. He was kind of drinking a lot, and he was kind of getting depressed to the point that he wanted to kill himself. So he was suffering from being alcoholic, being depressed. But one of the things that didn't make sense to me was he doesn't have as good a memory as what we would typically see in a 60-year-old. So basically, we kind of got worried. We kind of asked him, hey, do you have any friends that know you? And the good thing was he actually has a church pastor that we get to talk to. And the pastor was like, Dr. Wu, this guy was getting a little bit stranger every week. Used to be he would come to church every week. Now he's kind of like just getting drunk and not showing up. But we kind of got worried because there's a personality change. And when we scan his brain, what do you guys see or what not see? Very typical image of someone suffering from alcoholic damages leading to some frontal lobe being gone. And no wonder he was feeling depressed, personality change, and having this worsening of dementia kicking in. So just kind of keep that in mind. Even though when we talk about psychiatric emergencies, the most important thing to keep in mind is first, think medical. If you are able to kind of rule out the medical causes, there's a lot of times that we could avoid an admission to psychiatry. And the other thing to kind of keep track is, when you guys are in the emergency room working as medical student, a lot of times you guys are the ones getting the important clinical information. So keep that in mind. 2 more years, I'll be seeing you guys, doing me a favor, make sure you guys call the family members. That's a lot of the times that we actually solve a lot of the problems. So in psychiatric emergencies, after we kind of rule out, the medical problems, the things that I start asking myself is, what exactly is the psychiatric diagnosis? And I'm sure you guys have already learned about the DSM method of kind of like looking at what are the diagnoses. Unfortunately, in a psych emergency room, though, you only have literally like 5-10 minutes to kind of make up your mind what they are. So even if we really want to say we base it on, the DSM-5, DSM-4, a lot of times your diagnosis may not be correct. It could be as simple as, just like the constipation causing the psychiatric illnesses. So one of the things that I start looking at was how legit or how valid and how reliable are those psychiatric diagnoses in the emergency room. And basically we calculate the CAPR, and if you look at it, the legit major psychiatric diagnoses like schizophrenia, we are only correct 1/2 of the times, meaning myself, yourself are equally as good as guessing whether this is, the head or the tail. But one of the things that we realized was that if the police actually writes a more comprehensive legal host, we are more likely to come up with the diagnoses. That's no difference from when we actually have a patient in front of us, kind of like banging on the window, throwing at the knife. You cannot rely on that particular patient to give you the information. But instead, if we start calling the family members, talking to the police who brought the patients in, that's the moment that you could really solve a psychiatric crisis. And the other thing that kind of came up during this research that I did was that the patients that we tend to have a different diagnosis on discharge were the ones that have a higher medical burdens. And this seems like counterintuitive because you'll be thinking like, hey, Dr. Wu, they already have like hypertension, congestive heart failure, hyperlipidemia, diabetes, and everything. Why do we need one more diagnosis? The truth is, we, all being medical doctors, need to be very careful when someone comes in with 6 or 7 diagnoses because there's always one new medical problems causing their illnesses. So kind of keep that in mind. Just because they have tons of medications, make sure we look at each one of them one by one. And when in doubt, though, call the family. So when we talk about psychiatric emergencies in a clinical system, though, there's 2 different ways of us to deal with it. The first is like the consultation model. Enough of you guys will be, going to the 3rd year, 4th year rotations, and you guys will serve as a consultant, meaning that usually the internal medicine folks are the ones taking care of the patients, but you as a future neurologist, urologist, different services will be coming to consult with this patient. And versus there's a primary model of just taking care of the patient. And in psychiatric emergencies, there's no differences. You have the consultation model, which is pretty much used in big counties like Los Angeles, San Francisco, and some of the counties in New York, versus the psych emergency systems. So one of the things that I started looking at was, are there any differences when we use different systems to take care of patients? And one of the things I highly recommend you guys to start thinking about is, on top of your COMLACs, of your step 1, what kind of doctors you want to be? Being a consultant, the nice thing is you actually just pretty much work for 12-hour shift and you get to go home. Versus if you work on a primary care model, psych emergency room model, you will be there quite some times. But that's something for you guys to ponder on your 3rd or 4th year rotations. But one of the things that I realized is if you guys start looking at the pregnancy testing, for example, we will make the assumption that any females who come in should at least get a urine pregnancy because at least that way we could avoid giving them unwanted medications. Unfortunately, if you look at it, when emergency room doctors are running the show, only 68% of the times a female gets the pregnancy testing. Versus in a psych emergency model, only 80%. So if there's one thing that I could share with you guys though, as a 3rd year medical student, one thing that you guys will make us, the so-called attendings, really love you guys are order pregnancy testing. Because there are enough medications that we will accidentally give to our patients. I'm going to kind of like talk about a slide that is upcoming pretty soon. But one of the emergency medications that we give to patients who are acting up is Haldol, which is haloperidol, Ativan, which is lorazepam, Benadryl, just like how someone was talking about earlier. Which one of the medication is the one not to give to your pregnant ladies? So once again, haloperidol, lorazepam, or Benadryl, diphenhydramine. So I always assume people are saying the right answer, right? So Ativan, lorazepam is the one you need to avoid giving to your pregnant ladies. And the reason I'm drilling to you guys on this one as a MS1 is the following. Even as attending, I'll be honest with you, when was the last time I gave Ativan to a pregnant lady? Within this year. So kind of keep that in mind because a lot of times when someone's acting on an emergency, you will not remember. You may not even check with the nurses whether they are pregnant or not. And next thing you know is you order the most basic medications thinking that you did the right thing. But the last thing you want is to harm the patient. So remember, Rule number one, do no harm. So, but when we start looking at some of the other quality indicators though, the psych emergency room actually does a better job on like doing mental status examinations, evaluating the patients more on time. But just kind of comparing the two different models though, you could actually see that we still have a long way to go in terms of how to best deliver quality of care to our patients. So if any one of you guys are thinking about Master of Public Health though, definitely look into how we could provide quality of care for patients who are acting out, because that's something that we are always looking into. Any questions so far? Okay. So then one of the things that I start looking at is, do elderly patients and adult age populations come in differently to the psych emergency rooms? And if you guys look at the statistics, they definitely do. One of the things that I learned is our geriatric population, be it that they don't have their family members around them, or they were just kind of like alone, losing their loved ones, tend to be there at their home more often. So the only times that they will get contact for their psych emergency is when the mobile emergency team, which in Los Angeles is basically the police kind of doing a welfare check. And that's why one of the tips for your shelf exam for your step one is that elderly abuse is always a topic to kind of think about. And in fact, when you guys do your OSCE though, don't be surprised that your actors and actresses have some lipstick kind of like drawing, on their ankle that looks like, someone is tying them down, that kind of stuff. If you don't see that on your school OSCE, you may see that on your other OSCEs as well. That's kind of like the elderly abuse. But a lot of times though, what we realize is if no one goes check on the welfare or the well-being of this elderly, they may actually be kind of like dying at home. And I'm sure when you guys are studying your step one or your COMLEX, one of the things to remember are the demographic risk factors for people who actually kill themselves are elderly, Caucasians, males with guns. So that's more important for us to kind of look at how we deal with the elderly. And if you guys are kind of curious, what do we do with like the pediatric psych emergencies though? We do in California have what's known as wraparound services, social worker, caseworkers, they all come to the psych emergency room to help those kind of kids. Hopefully they get de-escalated and kind of help the parents to take them back home. But the youngest kid that I ran into in the psych emergency room was 3 years old. And the reason that he was brought into us was he jumped out from the car. So kind of keep that in mind. It just seems like psych emergencies is going to be happening a lot and a lot. And no matter what you guys plan to go into, peds, geriatric, IM, even surgery, you guys will need to be contacting us. So just kind of keep that in mind. If the last thing you remember from this lecture is do no harm, always also remember, if you're taking care of your OB patients, don't give them Ativan. So we did kind of briefly mention about suicidal risk factors and stuff like that. This is a research that I did with a few of the DO students that I had a few years back. And we were kind of looking at how emergency room doctors kind of like deal with the suicidal patients. And what we want to find out was to look at the quality they are providing to the suicidal patients. And what we did was that we first come up with a list of known suicidal risk factors. For example, when we kind of talk about suicide, we always ask the patients, are you still being suicidal? If they say they do, whether they have a plan, and if they say their plan is to get in front of the train station in Pomona, we have to take those pretty seriously. So we were kind of going through each one of those quality indicators and see how this particular emergency room does in dealing with suicidal patients. Anyone going to ED for residency? Wow, at least 4, 5. So do remember, when you guys go into emergency room for residency, one of the things that they always look for is whether you did some research at Arrowhead or one of those places that you guys rotated at. Suicidal patients are always the easiest to do research on because you literally could just apply some of the risk factors and see whether you guys are doing quality care for those patients. So this is what we did. We looked at about 145 patients who came in, who was brought in by the police for being danger to themselves. And half were males and females. And enough of them were young enough, 37 years old. You kind of see that, we have the same kind of diagnoses: psychosis, depression, bipolar disorder. And for the emergency room doctors, they do a pretty good job on documenting whether they have a gun. I guess, at med school, we kind of trained everyone well. First question to ask is, do you have a gun? But let me just kind of give you guys a heads up, though. If you guys are going to Florida, and if you go into pediatrics, you are no longer to ask whether they have gun inside their house. So that's something to kind of ponder on, think about when you apply for your residency, okay? And then the emergency room doctors do a very good job looking at whether they have any kind of stressful life events. And last but not least, you guys will always hear about this term, contract for safety. What it means is that us doctors is asking those patients, can you tell me whether in the next 24 hours, whether you could avoid hurting yourself? It's really that silly. But when we look at, some of the things that we hardly document is history of abuse. If someone has history of abuse and now they're having flashbacks, are they likely to kill themselves? I would make the argument that they will. Command auditory hallucinations. What it means is that you're hearing Dr. Wu's voice telling you, you need to kill yourself if you're not falling asleep in my lecture. So that's command auditory hallucinations. And strangely, I was so shocked when I found out only 1/3 of the time we were actually documenting whether they have a suicidal plans or not. Meaning, we kind of just asked them, hey, are you suicidal? And then we just leave them alone, and we didn't ask them whether they have a plan. That may not sound important until when you guys, running the show, and their plans is, I'm going to take myself down, but guess what? I'm going to take my doctors down also. So always remember, when you ask about suicidal ideation, ask them whether they have any plans. Because the last thing is, of course, their lives are important, but hopefully our lives are pretty important also. You don't want to get hurt. And one of the things that has been shown in research is that hopelessness is always a main driven factor, whether someone is going to hurt themselves. But yet, in an emergency room, or I should say in a busy emergency room, only 1/3 of the time do we document about someone being hopeless or not. So before I kind of talk about this, though, I do have to acknowledge that, does it mean that if the doctors didn't document it, we didn't ask? Not really. They could have asked, but they just forgot to document. So you guys might be like, oh, the emergency room doctors did a good job. But do remember, when we get sued, what counts? Whatever is on the paper. So if one day Dr. Wu forgot to document, like, my cat is planning to kill me by her claws, and then, I got killed, whose fault is it? Myself. So always remember, even though you guys right now are busy studying for your first year, try to develop the habit of documenting everything, including documenting when was the last time you go to the bathroom so you don't get constipated and being brought into my psych room due to constipation. So I was kind of referring to the emergency room folks who might be applying to residency. Enough of the emergency room literature has looked at what's the easiest way to screen for suicide. And this is actually one of them. It's called Sad Persons, and basically it just goes by, like whether you're male or not, your age, whether you're suffering from depression, whether you have previous suicidal attempts or psychiatric care. And if you scored about 7 to 10, then you are high risk. So some of the research that in the emergency room that we have been doing a lot is to kind of track this kind of patients and see how we could best help them. For example, providing a case manager to call them within 24 hours after they were being discharged from the emergency room. So I'm just kind of throwing ideas for you guys to think about what to do for your future poster, papers, and things like that. So we did talk about the systems level, like, the psych emergency rooms versus the emergency rooms with a consultation. But what exactly is the Institute of Medicine telling us to do? First, do no harm. We need to be safe. Not only we need to be safe for the patients, we need to be safe for ourselves and our colleagues. Second, try to provide the effective methods of helping them, meaning that if you don't have to give them intramuscular injections to calm them down, use your verbal techniques to kind of talk to them, and hopefully we'll be providing the most effective methods. Third, we need to be patient-centered. Not only we have to think about how to save our time on night so we could go back to sleep, we need to think about the wishes of the patient. Fourth, provide timely evaluation. This incident happens a lot, at least when I was a resident. It's always easy to remember your pager is on, but you forgot to answer the phone call. So do me a favor, no matter your third year, fourth year, first year intern, or even an attending, keep your pager on, keep your cell phone on. You don't need to put it near your body for it to vibrate or something like that, okay? But always remember, be timely. And try not to waste a lot of resources being efficient. A lot of times, though, we see folks ordering tons of labs, tons of things, but we may not even need it. And like today, Monday, when I went back to work at Oliveville, one of the nurses were asking me, "Hey, Dr. Wu, we got the labs already on Saturday. Why are you ordering the labs again today?" Oops, I didn't check the labs on the weekend, that's why. So do remember, it happens all the time. So we always need to keep each other check and balances. And I always tell the students who come rotate with me, if you catch my mistake, let me know. Same thing with you. If I catch your mistakes, I'll let you know also. And that's about equitable. So we did talk about elderly, and this is some of the things that I want to kind of suggest to you guys. In the medicine world, if you have a special population, adolescents, elderly, regardless of which specialties you plan to go into, it's always easy to publish a case report, posters, or any kind of research. So one of the things that I did with undergraduate was that we look at whether elderly population come in differently with their substance abuse. Because at med school, I was always being taught that if you are elderly, you are not likely to abuse illicit drugs. And when I did this little study, I was like, oh my, I was wrong. Apparently, elderly comes into the psych emergency room with as frequent or as prevalent substance abuse problems. So kind of keep that in mind. Just because you have a sweet elderly coming to you, having the canes, asking for pain pills, they could be selling their pain pills on the street. Does that happen? It does. And the next thing you know is they may be kind of like going around shopping for doctors to give them their opioids or other pain pills. So always remember, if you don't want to lose your license, make sure you check whether they are abusing any kind of street drugs or even doctor-prescribed medications. And it doesn't matter whether they are young, old, or adult. And actually, before coming in to Western today, I was at Oliveville, and we just kind of got a 20-year-old guy who basically was a bounce back from the medicine services. He was withdrawing from alcohol, and then he kind of got cured, and then they sent him out to the shelter. Problem was, they forgot to give him his lorazepam for alcohol withdrawal-addiction. So then he told the folks there, I am suicidal. So now he's with us in the psych ward. And of course, you have to start asking yourself, is he really withdrawing from alcohols? Or is he just kind of like lying and hope that he gets a few extra Ativan before he goes? But that's the kind of situations you guys will be dealing in a so-called psych emergencies or in an intensive crisis for psychiatry. Alex Chang was a graduate from your program. He's a PGY2 at UNLV in psychiatry right now. This is one of the things that we did, kind of asking ourselves, do police, can they tell whether someone is high on meth versus they are having a bipolar schizophrenia crisis? And if you look at the bottom one, the legal status, you could see that the groups with meth positive illnesses, amphetamine disorders, versus the groups without. There's no differences on their legal status holds, meaning that the police actually just kind of see someone acting high, acting crazy, and they will be brought in to the psychiatric emergency. So one of the things that we kind of ask ourselves are, can we come up with some kind of demographic factors? You know, like the sad persons, like whether we could kind of know who are the folks. And the only thing that we sort of figure out is if they are the younger population, if they are the uninsured population, they are more likely to come in with methamphetamine being positive. So kind of keep that in mind. Something like this is very easily done. And I'm sure you guys will be offering a lot of times to your faculty at Weston. So make sure you guys come up with something like this and you have a nice poster, nice paper. Next thing you know is you'll be in a nicer residency. Wait, that's something to think about. Come on, it's important. All right. So we did talk about Ventura County, which is kind of like up north on the west side near the ocean. Channel Island, do you guys know where that is? Go to the national parks. You guys have time. Come on. I was just at Olympic National Park a while ago, and like all my students were complaining, saying like, hey, Dr. Wu, why am I seeing you are not at the hospital? And I'm seeing like all of your pictures from Olympic National Park. But remember, I don't want to lose you guys as future colleagues, so make sure you are studying enough. And sitting here is actually hard. I remember myself falling asleep all the time when I was in your shoes. Okay, so this is something that kind of got my attention. Remember back in like 2009, we have the economic crisis going on in the nation. So one of the things that I kind of asked myself was, this is a gold mine. I could just look at the psych emergency room and see whether there's more people coming into the psych emergency room. So what I did was that I compared 2008 versus 2009. And in 2008, there was only 5.7% unemployment rate, versus in 2009, it was already up to about 10%. And so deep in my silly mind, I was like, if the unemployment rate goes up by 2 times, I would see as many people coming in. And to be honest, I was so shocked to find out that approximately the same numbers of people come in, meaning the absolute numbers didn't change. You guys might be wondering, like, isn't in an economic recession, like number one, your psychiatric patients, the ones with the disorders, they won't get better. And at the same token, like our loved ones, families, friends, they may actually be coming in because they lose their jobs or they just become depressed. So one of the things that I realized is when we kind of look at it from a clinician, doctor level, we don't think about the big picture. Because when unemployment, economic recession kick in, what happened? The police are losing their job, the county employees are losing their job. So there are lesser people working in a healthcare system. So guess what? In the economic recession, lesser psych patients are being brought into the psych emergency rooms because they don't have time to deal with it. So the things that we kind of found out was indeed that's the case. The folks who came in economic recessions, more of them do not have a previous diagnosis. So that kind of goes back to what we were kind of talking about, like, your loved ones losing jobs, now coming in because they are suicidal. And of course, they are more likely to have like depression or substance disorders. So that's just something for you guys to ponder on. In economic recessions though, on one hand though, we will be dealing with more psychiatric patients or psychiatric emergencies. But it also depends on our counterparts, like the police system or the other folks to kind of help bring the patients into a psychiatric emergency room. So if you guys are interested in this topic though, I highly recommend you guys to read this book called The Body Economic. It's kind of talking about how we should do in economic recessions, at least to kind of give you guys a policy, kind of thinking about what we could do. This is another study done by one of your graduates, Jan I. She's now a second-year ophthalmology resident at Michigan. She came up with this study, so I have to give her all the credits. she was basically asking me, hey, Dr. Wu, when was the last time you asked your patients whether they wear glasses? And I was like, half the time. And she was like, when was the last time we asked the patients whether they wear contact lenses? And if you kind of think about what kind of patients that I deal with, you know, they are the ones being brought in by the police against their will. Usually, do you guys know how I will know whether someone is wearing contact lenses or not? If their eyes become red, they are tearful, they are screaming hell, they are saying, I'm going to kill you, I'm going to kick your ass. That's when I found out. So we basically want to confirm whether that's indeed the case. And lo and behold, we basically found out that we never asked any of the patients whether they wear contact lenses or not. Is that part of your OSCE to ask about whether patients wear contact lenses? Well, you guys are better than me, so keep that in mind, okay? So when patients are being brought in, though, at least ask them whether they may be wearing contact lenses, because that could kind of like exacerbate their psychiatric and medical problems. At the very least, though, think about the elderly patients. They may actually need a reading glasses, but they don't have it. And guess what? That's not part of the services that a hospital provide. I will tell you many stories that me and my medical students ran to CVS to get like denture glues, to get like reading glasses just for the patients. But that's what we all will be dealing in our long professions. So I'm sure you guys have already kind of read through the DSM-5, kind of know what are the criteria and stuff like that, right? Perfect. So, question. How long does it take for you to diagnose a manic episode? One day or 1 week? 1 week, right? Under what circumstances? Dr. Wu could have 2 days, 59 minutes, 59 seconds, 59 nanoseconds of mania, and you could diagnose me with manic episode. Someone just said it. Thank you. How often would a third-year medical student answer that question correctly? 10% of the time, so congratulations. You are in the 10% of the time. So if there's one thing that I could share with you guys though, sometimes the shelf exam may look like that silly, like really people ask about you get hospitalized, but we only have that much to test you guys on, so kind of keep that in mind. And don't get angry or nervous when, you know, during your third year pimping sessions, people ask you those kind of ridiculous questions, because we just want you guys to do well on your shelf exam and on your future exams. So I'm sure you guys went through the 5 major diagnoses, so I'm just kind of going to give you guys some examples. How many of you guys have heard of Steve Lopez before?
Excuse me. Can you repeat the answer to the question about mania less than 1 week?
Oh, sure. So basically I was asking, like, if you don't have the 1 week, let's say you only have like 2 days, 59 minutes, the only way you could be diagnosed with a manic episode is when you are being hospitalized, okay? All right. I highly recommend you guys to go watch this movie, The Soloist, or if not, go grab the book to read. Steve Lopez was the LA Times reporter, and Nathaniel Ayers was the schizophrenia patient who actually was a Juilliard dropout, and he was playing a 2-strings violin on the street. This is kind of the patients that we deal with a lot of times at Oliveville or any one of the 3 county psych emergency rooms. The movie is called The Soloist, and it's by Jaime Fox, so take a look. All right, now a real case. So you have a female who was at the UCLA Medical Center parking lot at 2 a.m. And she was kind of like racing, running around, looking for her car. And when her friend was already slowly crashing from alcohol and stuff, this lady kept yelling, "I want more." Any differentials? So could be drug-induced, could be a manic episode, could be psychotic, or patient could be malingering, right? That happens all the time. People lie. So the campus police actually put her up and asked them who they were. And she actually said, yeah, I'm on the faculty here at UCLA, Department of Psychiatry. And guess what? The police actually left them alone. Doesn't happen nowadays. If I was the one running around at the campus like that, though, trust me, someone would lock me up for 72 hours. So this is indeed a true case. And actually, this lady is a very famous lady. Her name is Kate Jamison. She actually wrote one of the national bestsellers. She's now a professor at Johns Hopkins. So if you guys are ever interested in learning more about mania, bipolar disorder, I highly recommend you guys to read her book, An Unquiet Minds. It's one of those easy reads that you'll finish by a weekend. Do it after the step one, though, please. All right? I'm just going to skip some of this here. Let's see. So, does this picture ring a bell by any chance? That's the residency program that I work for. So when you guys come to third year rotation to rotate with us at Oliveville, we'll make sure you guys go take a picture like that. All right? So with that said, let's give you guys a 5-10 minutes break, or how long is it usually? Well, make it 7, so we'll end earlier. How's that?
Can I ask a quick question? How many of you are having trouble with Dr. Wu's PowerPoint? Lebanon, are you having trouble opening the PowerPoint? No, nobody. Okay.
I can even explain after class.
All right, let's start. How's that? So, some of you guys just give me the good news that my PowerPoints are crashing. How many of you guys are having PowerPoints crashing issues? Just because I'm a psychiatrist, I do not do that kind of things to you guys. Stop thinking that I'm controlling your computer. Okay? No more ideas of references. But as psychiatrists, though, we always kind of like, ask ourselves what's going on. But problem-solving time now, right? If one of you guys are having a problematic PowerPoint, what should we do? Look at the next person. If that person doesn't have a problem, have that person send it out. Perfect. All right, so this is a psych emergency guidelines that me and a few other colleagues in the nation came up with. It's called Project Beta. Basically, it stands for the best practices in evaluation and treatment of agitation. And some of you guys are kind of thinking like, why is this guy keep talking about research and crap like that? To be honest with you, most of the research that I did was back when I was a resident. And you just have to pick the right territory. If you pick something exotic and interesting, it doesn't matter you are just doing 1 + 1 = 2. People will be publishing your work, and you will be getting on some guidelines like this. And in fact, we have a third-year med student sitting here already having 2.5 papers published from your beloved school, Miss Lydia. So anyways, so it's not that hard. Make sure you guys find someone who is willing to work with students, and make sure at the minimum, trying to get a case report. Case report is very straightforward. 500 words, you write it, you're done, like that. Same thing for the Oregon campus also. Like, always try to look for those kind of opportunities. And before we go on with this Project Beta, can I just say something for your future career, or should I move on with the lecture? Okay, well, keep it to you guys, okay? Number one, for the people who are in lectures, you are in luck. Make sure you choose olive oil for your psychiatry rotation, duh. But more importantly though, this coming summer, try to get like a case report. Talk to your school faculty. You will be surprised how many faculty members are just in need of someone writing up an interesting case report. One case report is literally enough for the residency program. So keep that in mind. So just want to talk about what kind of things do we do in psychiatric emergencies. So the first thing is we have to do a medical evaluation. Remember, we are all doctors by training. Second, do your psychiatric evaluation, like whether your computers are being controlled by the guy who's speaking right now. Third, when someone's getting angry though, always try the least restrictive methods. How do you verbally de-escalate the patients? Fourth, then we kind of go into giving them PO medications or IM medications. And actually, do you guys want to guess what's the best medications in a psych emergency? Food. Always ask them, hey, food works or not? And in fact, today, we were about to tie a patient down, but we gave 2 Kit Kats to a diabetic patient. But which one is more important, you being assaulted or him having a diabetic crisis? Wow, no one's being honest. I will tell you, I don't want myself to get hurt. All right, last but not least, use and avoidance of seclusion and restraints, and we talked about it already. Kit Kats. All right? So the first thing is, when you kind of evaluate your patients, you don't wait till you're talking to your patient. When you're kind of like, being far away from your patients, you start looking at them and kind of making your differential diagnoses. If you see that their fingernails are too long, what should you do? Make sure you are like me, wear glasses, or else you better not stand at the side that he could go like this. Oh, you could go like this, all right? All right. And second thing, do remember, the only times that you as doctors or myself as psychiatrists that we could really calm the patient down is only when they're at level 5 or 6. Meaning they're kind of getting, acting up, but they could listen to you, or they're kind of like, walking around, kind of pacing around the unit. By the moment that they're getting violent and they are requiring restraint, there's really no point in talking to them. Because next thing you know is, they may actually bite off their cheeks and use that as weapon at you. And in fact, that happened to me and my colleague about 6 years ago. The guy was HIV positive, and he was determined to get us. So kind of keep that in mind. If patients are already getting that violent, step back, okay? So enough of you guys are going to emergency rooms, but hopefully some of you guys are coming to us psychiatry. So this is kind of like my ways of kind of thinking when to send the patients to the medical floor versus the psychiatric floor. One of the things is, when we talk about psychiatric patients, most of them actually don't have loss of memory or disorientation. So if they are having those kind of symptoms, make sure you send them to an emergency room than the psychiatry side. Second, having severe headaches. Can tell you how many times just by asking the patient that question. Do you have a severe headache? It avoids me from having a medical crisis on my side. And one thing though, if you're kind of like hearing a patient talking about like he or she feels like, I'm so hot right now, I'm so hot right now, start thinking about your medication crises such as like neuroleptic malignant syndrome, serotonin syndrome, and in that time, your patients actually need IV. They don't need to be in a psych floor staring at me. So keep that in mind also. And if you are seeing them turning blue, please send them to the medical side. You guys haven't been to your rotations yet, but one thing, when we check vital signs, nurses always remember to check blood pressure, heart rate, respiratory rate. But I always find it difficult to find my oxygen rate. And it really literally takes the patient to turn blue before your nurses will call you. So just kind of keep that in mind. So some of the factors that could indicate a serious life-threatening issues. When something happens when you are in your middle age, 45 years old, without previous illnesses, you need to keep asking yourself, this is not psychiatric. This could be medical. If your vital signs are abnormal, definitely start thinking about what to do in case the patient is crashing. And if you see that the patient is having some fluids draining from the head, please don't send the patient to me on the psychiatric side. Keep it in mind though, when you do a physical examination, meaning if you listen to their hearts and lungs carefully, you listen to their bowel sound, you only have about 51% of the times that you will detect a medical problems. Yet, if the patient could actually talk to you, and if you literally ask them, do you have any kind of medical history, or just ask the family members, you have a 90% chance of detecting their medical problems. So always remember, if you have a psych emergency, and if the person is not talking to you, call the family. Seriously, that would solve you a lot of problems. One time we had a patient who was basically lying on the floor, kind of not moving around. Everyone thought that he was catatonic. And that was back when I was a resident. My attending literally just brought an orange juice, gave to the patient. The patient was like, hypoglycemic episode. Those are the times that when you earn the respect of your future colleagues. So just kind of keep that in mind. A lot of times things could look one way, but they actually could be a medical crisis going on. So some of the things that I want you guys to think about is, what kind of medical problems could make us look aggressive or agitated? When you have a head trauma, when you have encephalitis, when you have thyroid storms. And in fact, I can't tell you how many times that I would send, third-year medical students into the room, and the patient would be looking like this. And everyone's like, wait, that's a thyroid storm. That's the first time they're like, how did we screw up? How did we admit this patient to the psych floor? So just remember that when you see your patient's eye sticking out though, think about whether they may be having a thyroid storms. But there's a lot of reasons to cause like agitation and aggression. You could be like withdrawing or being high on drugs, or could be your psychiatric illnesses kicking in. So just kind of keep that in mind. Think medical, then think about whether they have substance issues. And last but not least, if you work everything out, what else could it be due to? It's April 30th. Why would they be in the psych floor trying to beat the crap out of you? They need a place to stay, malingering. I think one of you guys who just told me he worked at San Francisco General Hospital had those things all the time. Always remember, if you suspect that your patient is here for a secondary gain, feel free to offer your food, your sleeping bag, but don't take them home, okay? But if you want to impress your attending, though, definitely take them home. All right, next. So we talk about medical illnesses or substance abuse leading to agitation. So what do I do as a psychiatrist? So the first thing that I try to look at is from far. I'm trying to walk you guys into their mental status examination. First thing I look at is whether they have any kind of weird appearances. I talk about the fingernails. But I still remember clearly that when I was a third-year med student, I had a case of a patient who was wearing sunglasses in the emergency room. And my attending was like, hey, Ben, you don't want to get too close to that patient. And deep in my mind, I was like, why? Just because he was wearing sunglasses? I'm bigger than him. I'm not afraid of him. Why do you guys think that someone wearing sunglasses in an emergency room? You might need to be a little bit careful. They may be like staring at you, and they are using the sunglasses to cover it up because, number one, you cannot see how angry their eyes are staring at you. But more importantly, what if they are actually seeing that you are the guy that they want to beat up? And that's why they're wearing the sunglasses, because they are paranoid. The other thing that used to work perfectly, and that kind of gives us, is when people are wearing the Walkmans and the volumes are so loud that you hear them from there. That's when they're trying to cover up the voices they're hearing. So those are some of the little things that you guys could get from the mental status examination. And the second point that I always emphasize with medical students is, it doesn't matter anyone has a psychiatric illnesses. If you have a poor impulse control, like you're pretty sick of this guy talking right now and you're ready to walk out, what are you going to do? You're going to walk out. Same thing with psych patients, us, or when you get drunk. So keep that in mind. Impulse control is one of the things that you really need to determine. And then the third things that we start looking at is whether they're going to hurt themselves, whether they're going to hurt other people. And just because they tell you they are not going to hurt themselves, though, always remember, if they have a knife right here, do you think they're going to hurt you pretty soon? I would say yes. Keep that in mind. I keep, repeating this point, and I apologize that it sounds like that's what I do in the psych emergency room, is to talk to the family. But seriously, that's what I do all the time. Talking to the family, number one, could help you figure out what medical problems they have, what psychiatric problems they have, but what's the most important reason you want to talk to the family. They need a place to go back to, and you are better off finding a place for them to go back to before it's too late. The only time we have hard times discharging patients is family members are angry at you and they don't want to take the patients back. We did talk about this. Documentation is very important. You guys might be like, hey, I'm in my first year only. When is documentation going to come to me? Truthfully, in less than 13 months, you guys will be in your clerkship rotation. Time flies. Before you know, you'll be graduating. So start doing that, documenting. Last but not least, though, we need to come up with treatment and disposition. Just like what I talk about. Talking to family is important, not just to find out what medical problems or what psychiatric problems they're suffering from, but where we could send them back to. And this is what I usually deal with my patients. Is it okay to pick on you? When was the last time you drank your coffee? 30 minutes ago. How did I ask the question? You know, in med school, we keep teaching you guys, ask, do you drink coffee? In a psychiatric emergency setting, let's be real. If I'm going to kill you, am I going to say I'm going to kill you? So when was the last time you want to kick my ass? When was the last time you think that this guy is so boring? All right? This is how you guys do it. And it works. When you are pissed off at one of the med students, you start asking them like, oh, when was the last time you drank? And if they say like yesterday night, then you start yelling at them saying, wait, you drank and you came to my rotation today? Don't get tricked. But actually, no. Be honest with me when you guys come. All right. So, what do we do when we work with agitated patient? And when I say agitated, it could be as simple as the guy's pacing around. They are like, just kind of like getting combative. First thing I want you guys to know, any psychiatric wards, any emergency rooms should have a panic buttons. Med students, when you guys come to rotations, first thing, I want you guys to find where's the bathroom. Second, where's the cafeteria? Third, seriously, where's the panic button? And occasionally, if you guys work at Oliveville, though, you will realize the panic buttons go on, not because we have emergencies, but because the attendings fell asleep, and that's why we knock on the panic buttons. All right? So one thing, though, try to not use restraints at all if possible. Reason is, restraints only solve the problems temporarily. When the patients get off restraints in a few hours, they start acting up, and you still have to deal with them. One thing that over my career that I kind of find out working is, when I feel that a patient is kind of getting roused up, getting angry, how do you guys think you guys could help me to help this patient to calm down? A show of force. When we have like 6, 7 med students and myself kind of like standing in front of the patient, usually they calm down. The more the people, the better. And allow me to tell you guys a true story that happened 2, 3 years ago. So we had a patient who was getting so combative and was getting ready to beat one of us up. And he accidentally tripped, so I sat on the patient. What would you guys do as medical students? This is what 2 medical students did to me. Dr. Wu, my school told me that we are not allowed to touch patients. I stared at them and I was like, hey man, I'm going to get hurt and you guys are going to get hurt. Sit on him right now. I'm not going to tell you who they are, but long story short, it's okay. If your attending is already trying to make sure no one gets hurt, do me a favor. If you don't like sitting on the patient, grab his feet. Even better, if you're a black belt, do something. So let's talk about the times that we don't need to sit on the patient. How can we verbally de-escalate the patients? First thing that usually works is kind of keep a distance from them. Let them know. You have your distance, and I have my boundaries. So kind of keep that in mind. And next thing is, use the softest voices. Let them hear you. The lesser you speak, the better you are. Talk to them like that. So that way, they have to listen, and they kind of forgot that they were about to beat you up, okay? And always ask them, may I provide you some food? You want some Coca-Cola? That's fine. No problem. But at the very least, though, let them know what happened. But ultimately, though, after de-escalation, talk with everyone. You never know how your staffs or how your colleagues are going to feel. I'm sure those 2 students are still pissed off at me because I told them to sit on the butt. All right? But how do we usually talk to the psych patients? Ask them, what helps you? Let them tell you. I always ask the patients, what medications work for you before? No need to say, like, I'm going to give you an IM shot. By the time you say that, though, they are more than likely to smack you. So ask them, what helps you before? Next thing, just let them know, hey, you may benefit from medication. Still give them the chance to pick and choose. Try not to go into the far end pushing them off unless you really, really have no chance. And guess what? If you are ready to just yell at them and say, I am going to give you a shot and I don't care, make sure you have 500 medical students behind you. But guess what? Med students never stand in front of me and protect me. No, seriously, that's really the truth. So do me a favor, if you guys come for third year rotation, stand next to me, how's that? I don't need you to stand in front of me. Next, not behind. I'm not going to protect you. Right? And don't tell me your school tells you guys not to touch the patient. Well, forgive me for that one. All right. So first thing is try to offer PO medications, per mouth. There's actually medications that melt in your mouth in psychiatry. It actually melts like charm. But if you guys have watched House season 6, melting medications may not work because they know how to cheat it. And one of the things that I always tell med students are, even if the nurses documented that the patient has taken their medication, make sure you go check in their room. Because one time we had a patient who left, when we lift the beds, all the medications were underneath. They know how to trick you. They're smarter than us. Come on. Next, you could give your IM injections. And for the folks who go into the emergency room, IV is king. But unfortunately, I don't have that. So I have to be happy with giving them either PO or IM, intramuscular. Has any one of you guys heard of joperidone before? Good. It's a black box medications, no need to learn about it. But if you ever go into one of the older emergency rooms, they still use it to kind of calm the patient down. But if there's one thing I could tell you, if you hear about joperidone, stay away from it, that's all. And one last question that I always want to just ask the patient is, are they on any kind of long-term injections? In psychiatry, we have medications that we give them that last for 1 month, and now we even have one that lasts for 3 months. So the last thing that you want is they are already having enough medications in their bodies, yet you are giving them 5 times as much the medications. So just kind of keep that in mind. So those are some of the medications that we give our psych patients, but since most of you guys may not be going into psychiatry, just remember, Haldol, Ativan, Benadryl, and if they are pregnant, what do you need to avoid? Wow, see, everyone's awake. So no one has taken any Ativan since the break time. Perfect. All right. You guys could read up on this chart when you guys go home, but long story short, if someone is withdrawing from alcohol, give them Ativan. That's pretty much what it is. Your Haldol is not going to do much. But if they are genuinely having an agitation crisis going on, give them your typical Haldol, Ativan, and Benadryl. So now we get to talk about patients' feelings. You guys are like, hey, this guy hasn't talked about what we do as psychiatrists. Isn't we should talk about their feelings? Bottom line, no one likes to be in restraints. If you guys want to, when you come to my rotation, I could, put one of you guys in restraints as a demonstration, or we could just accept the fact that no one likes to be on restraints. Are we fair? But if one of you guys want, feel free to be my guest. Used to be we would have, students or residents to demonstrate taking medications, but we don't need to torture each other like that, okay? So why do we put people in restraints? If someone is breaking the window, would you say that's enough for us to put them in restraints? Let's say if they break the furniture, I hope so, right? Under that circumstances, that's the only thing you could do. But more common though, when you guys are on the medical floors, remember the little elderly who was suffering from dementia and they may be seeing things and they're trying to pick at their IV lines, you want to put them on restraints just to avoid them from getting hurt. So no matter what fields you guys go into, you will be giving emergency medications, so know them well. And know how to rule out your medical problems, because the last thing you want is someone is withdrawing from alcohol, yet you are withholding your benzodiazepines from them. So those are some of the kind of restraints that you will be using a lot. And just, some of them are like the wrist and the ankles, but a lot of times though, you may have to go to the hardcore leather ones just to kind of avoid the patients from acting up, hurting themselves, or hurting others. So let's talk about documentation. When I was a medical student, to be honest with you guys, I never know that 50% of my time is about typing notes. And I think it's going to get worse as time goes on. Either you develop your own templates or you will be typing notes every day. But if you put in, and this is one of the reasons why you don't want to put someone on restraints, is if they're on restraints, you have to document more frequent. So according to the national guideline, if you have an adult who is on restraints, you need to assess them every 8 hours. That doesn't sound too bad. But guess what? In my hospital, it's every 4 hours. And if it was a resident-induced restraints, it's every 2 hours. So long story short, the more able you are to calm the patient down, the happier you will be, because you don't have to torture yourself documenting like crazy. And actually the nurses, however, has to observe and monitor them for every 15 minutes. You need to offer liquid, nutrition, bathroom every 2 hours. And you also need to remove them from restraints no less than 5 minutes every 2 hours. So just kind of keep that in mind. I mean, you might be thinking like, geez, how is this going to be doing with our exams? But when you kind of think about what we really do in clinical setting though, those are the things that could really save you an hour, so you could go to Facebook or, play with your Twitters or Google your patient. No, don't do that. But it gives you a lot of times to do your own things if you don't have to put them on restraints. So let's talk about, medications. We did talk about medications leading to psychiatric emergency, and I kind of alluded to NMS, serotonin syndrome, and stuff like that. But let's kind of go over our antipsychotics first. And do you guys have a lecture on your antipsychotics already? Oh, perfect. See, by coming to this lecture, you guys learned something before. So one of the things that we think about is extrapyramidal symptoms, like their necks are all like stiff, their eyes are like really in ocular gyrus, their tongues are swelling. So those are the things that we as psychiatrists really worry about, because that's an impending medical crisis. And the worst ones that cause those kind of EPS is your typical antipsychotics, which, for example, like haloperidol. And among your atypicals, though, the worst one is risperidone. So just kind of remember that, because the last thing you want is you have a patient who's sitting on your medical floor and the neck is all like stiff like this and you don't know what it is. When you see one, you will remember for life. Then we start talking about long-term side effects. One of the nastiest side effects of the newer generation atypical antipsychotics are weight gain. And I'll give you an example. I had a patient who was about 30 years old, my size, and we gave him olanzapine for about 6 months. He became 310 pounds. So just kind of keep that in mind. There's definitely benefits. We help him with his psychoses. We help him to think more straight. But in the same token, though, he started developing side effects. What do you think the patient actually did at the end? Stop taking medication. Most patients do that, so keep that in mind. Some antipsychotics could lead to increased prolactin. Risperidone is one of the examples. Just kind of keep that, because it's going to show up on your step 1 and on your shelf and stuff like that. enough of your psychiatric medications will lead to sedation. And when you see a patient being tired, I want you guys to ask yourself, did we give a medication to make the patient tired? And if we did, we probably is better off taking away the medication. You guys could read up on serotonin syndrome. I'm just going to give you guys one clinical example. And this happened just a few months ago. We had a TB positive resistant patient on the internal medical services. And basically, the lady was developing prolonged QTC when we gave her antidepressants. And the internal medicine attending was like, hey, Ben, we actually have internal medical medications that looks like an antidepressant. And initially, I was thinking like, really? There's actually an IM medication, ID medication that looks like serotonin. And lo and behold, linezolid. It's one of the last line antibiotics that we give to like MRSA, methicillin-resistant Staph aureus patient. So if you guys kind of like, look at this though, you start thinking about, hey, there's actually a lot of medications that could lead to serotonin syndrome. And I'll kind of talk about what are the symptoms for serotonin syndrome. But I want you guys to start thinking about there's a lot of drug-drug interactions. And while you might think that at the hospital, your pharmacist may catch those kind of drug-drug interactions, usually it really takes a medical crisis before someone is going to notice it. So keep that in mind. Know your drug-drug interactions. How many of you guys have heard of neuroleptic malignant syndrome? Okay, all right. So neuroleptic malignant syndrome is like literally the #1 medical crisis in psychiatry. Patients usually get exposed to antipsychotics, and what happens is they start developing a high fever, and when you check the labs though, the leukocytes, their white blood cells, went up to the thousands. Their creatinine, CK, and the creatinine all kind of go skyrocketing. It's because the muscles are kind of contracting nonstop, muscles are breaking off, it clogs your kidney, and it also leads to white blood cell increase. It's kind of a situation that we need to send them to the ICU. So I really want you guys to know what's neuroleptic malignant syndrome. And the first thing to remember is you are always going to be presented with a patient who just got exposed to antipsychotics. Next thing is they have a fever. Sometimes you guys are like, oh, maybe it's infectious. And that's why you see the white blood cell being increased. But if you forgot to order the CK, which is to determine whether muscles are breaking down, then you won't realize it's a neuroleptic malignant syndrome. So keep that in mind. Actually, this is one of the case report that I did back when I was a resident, and we were kind of looking at neuroleptic malignant syndrome. This case was different. Basically, there's a question asking how often do we see neuroleptic malignant syndrome? And I think, to answer that question, let's kind of think back a little bit. Most psychiatrists actually work in the outpatient settings. They deal with more depressive cases or mood disorder. So most of the folks who see neuroleptic malignant syndromes are usually in the hospital. I think so far in my career, I have seen about 12, 13 of them so far. And usually, one of the things that really triggers me are the CK, which is the muscle breaking down. We're not talking about the thousands. We're talking about 25,000, 35,000, and the usual values for CK is like 0 to 200. So that kind of triggers me to think like that. But one of the things that we start noticing, at least at Oliver, is that for the atypical antipsychotics, we are not supposed to get as much neuroleptic malignant syndrome. And when they actually come in with a form of NMS, we have been seeing a few cases that they don't have any fever. So that's kind of making the diagnosis a little bit more harder to kind of differentiate. But as I said, as students, what's the easiest way to generate publications? Exactly. When you guys see an interesting case report, approach your attending and be like, hey, Dr. So-and-so, is it okay to write it up? 500 words, you are done. And in fact, this year, for the Western students that go through Olive-View for third year, we have about 4 cases that look interesting enough. I'm not going to torture you guys, but I will be the first person to admit, when we had a case called CDLS, I didn't know what it was. And as an attending, what's the easiest way to do when you don't know something? You tell the medical student, yeah, I know what it is. Go look it up and tell me about it. Yeah. All right. And also, if you don't know something, what's the easiest way to find out? Google it, right? Except remember, sometimes Wi-Fi may not work in your hospital. Ha, ha, ha. So know your medical knowledge well. So next thing I want to talk about is anticholinergic agents. And what kind of symptoms would your anticholinergic agents cause? We'll give you a nice one. You're mad as a hatter, red as a beet, blind as a bat. But some of the medications that could lead to anticholinergic situation could be as simple as your Excedrin, like one of you guys mentioned Benadryl, your antipsychotics Thorazine, or even just your atropine drops in your eye. But I really want you guys to remember, with anticholinergic, mad as a hatter, red as a beet, blind as a bat. It will show up on your step 1. If it doesn't show up on your step 1, it will show up on your step 2. If it doesn't show up on your step 2, it will show up on your step 3. If it doesn't show up on your step 3, you will see one in your life to appreciate it. And one of the things that got me interested in, let's talk about this one, yeah. Anticholinergic medications is the fact that in dementia patients, what they lack is choline, acetylcholine. So one of the little study that I did with another undergraduate was that to look at whether anticholinergic medications could actually cause behavioral problems in dementia patients. And lo and behold, we realized that as soon as we kind of fix those anticholinergic medications, patients' cognitive impairments get better. And this kind of study has been replicated over and over again. So I'll kind of give you a big example so you guys could kind of think about what to do. A dementia patient not peeing well, what kind of medical problems could this elderly person be suffering from? Have you guys heard of benign prostatic hypertrophy? Basically, your prostate got a little bit bigger. The medication to treat for BPH is actually anticholinergic. So when epidemiological study kind of looked at those patients, what they found out was long-term, those patients are more likely to develop dementia, cognitive impairments. So as doctors, what are some of the good ways for us to know what medications not to give to your elderly patients? It's known as the Beers criteria. And I guarantee you, if you go to your IM rotation, knowing what medications are on the Beers criteria, your attendings are going to be very happy. It's published by the American Geriatric Society, so it's okay not to remember for this part of the study because it's not going to be on your exam, but do know the name. So when you guys go to your third year rotation, you'll be like, yeah, I heard of Beers criteria. So just kind of keep that in mind. It's to kind of look at the medications that are inappropriate or unwanted for the elderly population. I want to talk about this one just because it's very interesting. When we feel nauseated or vomiting, we give medications, right? Did you guys know that anti-nausea medications could make you look like having dystonia or extrapyramidal symptoms? So basically, metoclopramide, which is Waclan, it's an anti-nausea medication. It's a dopamine blocker. So what is that alike? Antipsychotics, right? So do remember, we actually do give medications in the non-psychiatric field that could lead to psychiatric emergency. So please remember, at nighttime when you guys are on call, just because you're ordering Waclan for your patients to avoid nausea or vomiting, make sure you go check on your patient the next day, because chances are you'll be post-call, you won't go check on your patient. The day after you come back, someone's ready to chop your head off. So just keep that in mind. So we were just talking about serotonin syndrome, neuroleptic malignant syndrome, and anticholinergic delirium. So this is a chart for you guys to tell what are the differences. And all three of them are going to come in with tachycardia, hypertension. So your vital signs are not going to help you that much. Usually on your step 1 or on your shelf, though, you will see the classic presentation of patients having like myoclonia, hyperreflexia. Then you know that's part of the serotonin syndrome. And when you see your neuroleptic malignant syndrome, basically they will give you tons of labs, you know, like the CK, blah, 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 like that. Anticholinergic, though, do remember that med as a header. And that's the easiest way to differentiate among those three. Have you guys heard of this reported before? If you guys are interested in how medical problems could manifest as a psychiatric emergency, this is another good book to read on. Basically, Susanna Callahan was suffering from what looks like a bipolar disorder. She was kind of getting manic, very confused, very irritable, was kind of telling her fiance that she's ready to have sex with multiple people, but she turns out to have a medical problems. And the diagnosis was only made after she started having some medical symptoms. And they pretty much were fever, nausea, headaches. But in her case, the hospital got lucky because she was starting to have seizures. But one of the things that I highly encourage you guys to think about is, just because we are in this behavioral block of lecture, tie everything together. Because your medical problem, your psychiatric problems are always going to come together in one piece. And always remember, sometimes it's as simple as talking to the family members and be like, oh, your son is suffering from seizure? I didn't know. Or just be like, what does it take for your son or for your loved one to return home? You could be the facilitator. So just kind of keep those things in mind. But last few slides that I really want to talk about is suicide. We literally lose one medical school full of physicians every year. You know, burnouts is a lot. I'm not sure how many of you guys are already burning out. Chances are the ones sitting here would not be, because you guys still look pretty energetic. Probably are the ones sitting at home right now, so you know, we blame it on them, okay? But keep it in mind, keep your colleagues. And I highly, you know, one of the things that some of you guys just came to ask me during break time was, hey, Dr. Wu, how do I get into this or that? Do me a favor, tonight go home, find your match list, look at the person who got into the residency that you guys want to get into. If you want to go to internal medicine, I feel bad saying, well, Mohammed Shashahan got into Harvard UCLA, so he would be a good person to talk to. Ask him what are your advices. And if you want to talk about psychiatry, Agnes Kwan is one of the folks coming into my program from Weston. And there are tons of different people you guys could talk to. Every time when you guys, like first, second year students that I run into at the clinics, you guys are always asking me, hey, Dr. Wu, those losers don't want to talk to me. And when I go ask those people, they're like, no one ever talks to them. But you know, they walk your footsteps before. They are able to help you getting into the residency. And at the very least, though, make sure you talk to each other. Look at the person next to you. Make sure they're not like, you know, crying, being unhappy, because you guys need each other's support for the next 4 years. So, summary. We keep talking about the DSM. You know, I'm sure, you know, when you guys are talking about schizophrenia, you talk about delusions, paranoia, disorganized thoughts, hearing voices. But most of the times, though, when they come into the clinical picture, they don't just fit one thing. You can have a schizophrenia who is on April 30th, who doesn't have enough money, and they have to lie. And as such, they are here for housing. Substance disorders always complicate many psychiatric conditions. And don't forget, when I say substance disorders, it doesn't just mean your street drugs. We all give out substances. Keep that in mind. You will be surprised how many times you will see your names on prescriptions that you did not write. Did it happen to me before? Heck yeah. Always do think about medical problems. We are all doctors to begin with. And it is important to recognize patterns that may put people at risk. For example, if they're putting on their sunglasses, hearing their iTunes, keep that in mind. And remember, at the end of the day, this is what I always tell the students coming into my ward. The place that I work is an involuntary psychiatric ward. Basically, we do legal hearings to keep the patients in the hospital. And another advertisement, my site is the only site that gets to have students to do legal hearings. That's pretty fun. Come, okay? But at the end of the day, though, we get to go home, just like you guys. So feel free to contact me at my email and come to Oliveville, UCLA for your rotation. All right? Thank you. 4:45. Any questions? Going once, going twice. Yes.
Is there anything, any area you want us to focus on for the test in particular? Just there's a lot of topics.
There's an expert right there that I will refer you to. Any questions?
I just didn't catch the last thing you said. Remember at the end of the day, what?
You get to go home. That's very important. And as I said, rotation, what's the number one? Going to rotation, what's number one? Seriously, come on. Know where to find food. 2, where to find bathroom. 3, make sure you have your key so you can go back home. And don't get parking tickets or traffic tickets. It happens at third-year rotations a lot. There's a living example in this room. Mm-hmm. Okay. All right. Well, thank you.